Bismillah ar-Rahman ar-Rahim. Thank you very much for the kind invitation, Professor Ahmed. I will share with you one of the cases that I have been involved in its management lately. This was a patient from Libya. He is 45 years of age, and he is actually a fit patient. He was just hypertensive for about 5 years, and he came with an abdominal pain and severe chest pain. Examination blood pressure was 170, but he has absent bowel sound and weak bilateral femoral pulses. And working diagnosis was aortic dissection. So we said, well, let us do CT scan. And this was CT scan that was done in Libya, in Tripoli. And you can see that he has an aortic dissection after the subclavian artery. And the dissection goes all the way into the aorta with a big false lumen, and the true lumen is collapsed. And you find that the true lumen is at the middle of this, at the level of the celiac artery, is nearly fully collapsed. Now, not only the aortic dissection, but he has occluded his left kidney, he has left renal infarction, and he also occluded his inferior mesenteric artery, so he has an ischemic bowel. And this is the reason for his abdominal pain and absent bowel sound. So I've told the surgeon there that he needs to have an urgent TVAR as soon as possible. And the facility was not there at that time due to the condition at Libya. And you can see dissection continued to the femoral artery until both groins. I didn't know that he was a VIP in the government. And then this is the aortic dissection. You can see the flap. And the proximal landing zone was only 4.1 millimeter, which you need 20 millimeter. So we said we'll try to do a bypass, a carotid and carotid subclavian bypass to extend our landing zone. This is his presentation. This is how patient usually pathology specimen shows when the patient dies. So we discussed the case. I will go very quickly. And I want to show, it's very important to know what is a true lumen and false lumen, because if you put a TVAR at the false lumen and you sustain it, you actually can have mortality on the spot. So it's very important to know what is true and what is false. And the peak sign, which is the sign of this angulation, is the angle, the arrow, is the only sign which is 100% that will tell you what is false and what is true. And this one of the few cases, you can see this is the true lumen, and this one is the false lumen, which is down with the dissection. This is a study to show the radiological evidence, what is true and what is false. I will go very quickly. This is the true or false paper. This is the reference of it. You can see the cases. If you get a calcification like that, then the calcification show you the aortic wall, and it usually show you where is the false lumen and where is the true lumen. Sorry about the movement of the animation. I think because the resolution of the screen, it have moved a little bit, but this is what is true and what is false. These are the few cases you see. So I think it is crucial to know which lumen is true and which lumen is false. I'll go quickly. This is one of the cases that you get false lumen on both sides of the true lumen. So the true in the middle and false on both sides. And sorry about the arrow, it seems it has changed. I think essential when you do stenting, TVAR, you must have an endovascular training, and you must have also cardiothoracic training. You must know how to do thoracotomy. One of the nice technique to follow true lumen is the rendezvous technique, where you go with a pigtail catheter from the arm and pigtail catheter from the leg, and you hook them down. And then you can follow from down up to know where is the true lumen, because this is very important. So I will go quickly. We said we're going to do carotid subclavian bypass, but unfortunately he has lower neck abscess. So which make the whole management to be completely changing. For this, we had to do open thoracic debranching. So mini thoracotomy, you can do it easily. This is the small incision, and you get the thoracotomy and then you open a small thoracotomy incision, and you put a side clamp on the ascending aorta. We'll go very quickly. So, thoracotomy procedures that if you work in cardiothoracic unit, you probably have done it about 100 times. Then you open, and very easy the anatomy there, and you get a side clamp. On this side clamp, you can do the anastomosis between the ascending aorta and the left common carotid artery and left subclavian artery. You can see this is the bifurcated graft that we have been able to use to avoid the neck abscess. You can see it's pulsating. It was about 16 by 888 grafts. So very important to have an imaging of the false lumen. Transophyseal echo is one of the standards, and you can see this is the septum, and you try to be in the true lumen. So this is the case. You can see on the image screen here, transophyseal echo. This is the guide wire in the true lumen, which is collapsed. You can see it very obvious, because if your wire is in the false lumen and you put TIVAR, patient will die on the spot. So this is extremely important. So you make sure that you are in the true lumen. Actually, out of 10 chances going recanalization to the true lumen, 9 I was in false passage, but only once I was in the true lumen. And this once I've changed the wire into super stiff guide wire, and then this is a transophyseal echo, and after that you put the deployment. Well, after you've done the aortic thoracic debranching, well, any device will probably do, either C-tag, or you can use a lot of the new TIVAR devices like Captiva or Avion, which I have learned from Samer, have a quite advantage to be used over. So you put the thoracic endograft, the TIVAR, suddenly the patient improve on table, because on table you get the true lumen, which was collapsed, to be working. So you get intestinal perfusion, you get kidney perfusion. The anesthetist will tell you, well, patient's getting better, oxygenation getting up, his blood pressure is fine. So this was the only patient that asked me, can I get my bodyguards in ICU? We actually speak to 3 hospitals. We found 1 hospital approved that the bodyguard can come to ICU. I think because he was having problem with Libyan government. I don't know. But anyway, I wouldn't do it again if this patient come. And I hope to share it with you. And this is one of the late experience. Dissection is really a difficult case to treat. You need all experience and facility. And thank you very much for the kind invitation.